We have already discussed about vaginal and vulvar cancer, and now today we are going to discuss about the cervical cancer. So cervical cancer is much more common than the other two cancers which we have discussed earlier. It accounts for 20 to 25% of all gynecological cancers. Cervical cancer usually is seen in the age group of 35 to 55 years and is uncommon after the age of 65. This is among those rare cancers where we have been able to pinpoint the causative organism. And as you all know, the causative organism in most of the cases of cervical cancer is the high-risk HPV virus. Histologically, the most common type here also is squamous cell carcinoma. 20% cases are adenocarcinoma and 5% are rare varieties like adenosquamous carcinoma or neuroendocrine tumors. The four characteristic symptoms of cervical cancer include postmenopausal bleeding or postcoital bleeding, intermenstrual bleeding, or foul-smelling vaginal discharge. The characteristics which differentiate a cervical cancer growth from other benign lesions like erosion of cervix or polyp or a fibroid include that this growth bleeds on touch, it is friable, fixed and hard. You can remember it in a poetic way that it bleeds on touch, it breaks on touch, it is immobile and indurated. For confirmation of diagnosis, a biopsy is mandatory to find out the extent of the disease. An MRI is done, and to know the distant metastasis, usually a CAP-CT is done. CAP stands for chest, abdomen, and pelvis. PET-CT is not routinely included in the initial workup guidelines for cervical cancer, unlike vulvar and vaginal cancer. This is owing to the fact that PET scan is resource sensitive and is not universally available, especially in lower middle income countries where cervical cancer is most prevalent. Let's understand the staging in a way that we can remember it. Stage 1 is disease confined to cervix. Stage 4 is metastatic disease. Stage 2 and 3 are about involvement of vagina and parametrium. In stage 2, this involvement is partial, while in stage 3, it's complete involvement. That means either vagina up to its lower part or parametrium up to the lateral pelvic wall are involved. All stages are subdivided into A and B. For stage 1A, it means microscopic, that is, only seen by the pathology people, while 1B means disease is confirmed to the cervix, but we can also see it during a speculum examination. Stage 2A is involvement of upper vagina. As I told earlier, if the entire lesion, including that in the vagina, is less than 4 centimeters, it is stage 2A1. And if it is more than 4 centimeter, it means 2A2. 2B, as mentioned earlier, parametrium is involved but not up to the lateral pelvic wall. Stage 3A is when vagina is involved close to the introitus, and 3B is when parametrium is involved up to the lateral pelvic wall that will cause ureteric entrapment leading to hydronephrosis. In the year 2023, three modifications were made in the staging of cervical cancer, which are shown here in yellow boxes. So from stage 1A, that is a total microscopic lesion, the width was removed. So it becomes more easy now to remember stage 1A1 when the depth of invasion is less than 3 mm, while in A2, depth of invasion is 3 to 5 mm. In stage 1B, earlier there were only two substages, one B1 and B2. Now they have included one more stage, so it becomes stage 1B1 when the lesion is less than 2 centimeters, 1B2 where the lesion is 2 to 4 centimeters, 1B3 where the lesion is more than 4 centimeters. In stage 3 also, again one substage has been added, and that is 3C, which talks about nodal involvement. In stage 3C1 pelvic lymph nodes are involved, while in stage 3C2 periaortic lymph nodes are involved. For treatment, we have two options, either surgery or chemoradiation. Surgery means either it is radical hysterectomy with pelvic lymph node dissection or radical trachelectomy with pelvic lymph node dissection. The other option includes chemoradiation, which means teletherapy plus brachytherapy and chemosensitization. Hysterectomy versus trachelectomy. Trachelectomy means where you just are removing the cervix only. So how do you decide that? It is decided based on need of preservation of fertility. Let's make you understand the stage-wise treatment in a very simple way. We will start in a reverse order. The rule is if the size of the tumor is more than 4 cm, treatment option is only chemoradiation. Surgery is not a choice. This includes all cases beyond stage 2A2. If the tumor is less than 4 cm, surgery can be done. If the size is 2 to 4 cm, again there is only one surgical option, that is radical hysterectomy with pelvic lymph node dissection. If the patient is lucky and the tumor is detected when it is less than 2 cm in size and fertility is a concern, a radical trachelectomy with lymph node dissection may be offered. Very tiny microscopic lesion with a depth of less than 3 millimeters can be treated with conization or simple hysterectomy. After treatment for follow-up, the patient is called every 3 to 6 months for 2 years, and if there is no recurrence, 6 to 12 months up to 5 years. During these follow-up visits, assessment is done based on symptoms, per vaginal and per rectal examination. Remember, there is no role of routine pap test or HPV testing after patient has received radiotherapy. Imaging is indicated only when recurrence is suspected. Last question in this context will be, is prevention possible? For cervical cancer, as we know the cause, prevention is possible with three-layered approach. Primary with HPV vaccines and safe sexual practices, secondary with screening, HPV test or the pap test, and tertiary with early detection and timely treatment of the early cervical cancer lesions.